But something changed. In 1960, we had something called the Kerr-Mills Act, and for the first time the federal government began to pay some of the cost of health care for low-income Americans. It was quite limited. In 1964, they created the Community Health Centers Act. This allowed in areas like Moorhead, for instance, around the state of Minnesota and elsewhere, low-cost health care centers to provide care for low-income people at very low rates. They were somewhat supported in a small way by federal grants, by state grants, primarily by user fees and contributions. Guess what? They still are. Today there's about 7,000 or 8,000 community health centers across the country, many of them branches of other health centers. And they do a great job of delivering high quality health care to a lot of populations. In 1965, two things happened. We created Medicare and we created Medicaid. Medicare, just so we all know, is health care for individuals 65 and older. The only qualification for Medicare, other than being a citizen and having paid into the system, is that you achieve age 65. So it made it possible for individuals with high incomes and high assets to receive health care under Medicare in the same way as people with low incomes and very few assets. That may have been a mistake from the beginning to do it that way, but we do have a Medicare system now that provides health care to a lot of people. Now that I'm going on it, I suppose I'll couch my words a little bit, but I will tell you this. We have saddled our children and grandchildren with an incredible burden because of our Medicare system, and it needs revision seriously, and I'll share some of that down the road. Medicaid was health care for low-income individuals. It always was asset tested, which meant that if you had the ability to pay something, you should pay for it until you get a little more destitute. This is now changing under the Affordable Care Act in terms of who gets their health insurance subsidized. In '88, there was a Medicare Catastrophic Coverage Act passed that was rescinded the next year. And the reason I say that is because there is a history in our nation of passing major health care reform and then rescinding it when you find out that it's got a lot of issues. There are continuous changes at state and federal levels, continuous changes. We now have a very, very political health care system, driven not so much by the needs of individuals, but as much as by the interest groups that sit at the table and make the loudest noise and elect people to office. In 1994, we know President Clinton tried health care reform. Hillary worked very, very hard on this. It didn't go. It cost them the control of the House of Representatives. In 2003, under President Bush, we passed Medicaid Part D to try to help offset the high cost of prescription drugs. And then came 2010 with the Patient Protection and Affordable Care Act, which I call just Affordable Care Act now. That's the technical name after they combined the two bills and passed the second amendment to it. So here's how health care is done today, and this has really been since 1965. Legislative bodies meet. House of Representatives, the Senate at the federal level. In Minnesota, the House of Representatives and the Senate meet, and they consider ways that payers are going to pay for claims. Payers are the insurance companies. They tell them what they're going to cover. In Minnesota, on fully insured plans, there are 64 mandates. The average is 43 nationwide. Minnesota is a progressive state. Our Medicaid coverage is among the best in the country. We cover more Medicaid procedures than are required by the federal law. So that's done through the legislature. They tell the providers now more and more what they're going to provide and how they're going to provide it, especially under the Affordable Care Act. And the patients, that's us. We may or may not comply with what the doctors say, but we do like to spend health care dollars. In fact, some of the studies say up to half of all health care spending is unnecessary. Or, excuse me, let me rephrase that. Up to half of all health care advice by the doctors is ignored. This is when you get that pill because you don't feel good, and you go home and you take it a couple days and you feel better and you just don't take anymore. And eventually you pour it down the drain and we get three-legged frogs and all other sorts of odd things in our water. But we do spend a lot of money. And this is, if you will, our healthcare model that they started with in 2010. It really is a political system driven by political considerations that filters down through the healthcare system. And we, on this end, feel, or have come to feel, that we're entitled to the healthcare that others will pay for. Thank you very much. We now spend about 12% out of pocket. That's down from 48% in 1960. A lot of our healthcare spending is paid for by other people. This has become a problem. Well, what is a healthcare system? I like to look at it like this. It's a lot of disparate pieces, a lot of things that sort of touch each other. We have a family practice doctor, and then we have a dermatologist, and then we have a neonatologist, and we have a rheumatologist, and we have 39 specialties and subspecialties. We have specialty insurance companies. We have medical device manufacturers. We have pharmaceutical manufacturers. There are somewhere around 14,000 codes just for what they call CPT codes to identify healthcare procedures. We're now expanding that to ICD-10 with 100,000 codes to define every little thing that happens to you. There are actually 12 other ways of reimbursing doctors, 12 other code systems. Very, very complicated. But this is kind of what it looks like. Everything sort of touches each other, but it's not in a very orderly fashion. And so the Affordable Care Act came along and doesn't like that kind of disorder. And I mean this sincerely. This is the way that the authors of the Affordable Care Act saw health care. If we could only organize it into a nice box that we could run, things would be a lot better. It would be more efficient. It would be more accessible. It would cost less. And that's our goal. Unfortunately, health care, or fortunately, is not static. The day the ink dries on that law, it starts to change. It's like 3M, you know, a couple of guys meet in a garage and create sandpaper, and soon we have an international corporation. I wrote a book about the father of the artificial heart. In 1957, he sat looking at an orange juice machine, and he said, that's how I should make an artificial heart. And he spent the rest of his life developing that. All across the country, there are people doing that today who are going to revolutionize healthcare. And what we have today will not look a lot like tomorrow. And the question is, how do you organize that at a federal level? Does that help or does that hinder? Does it make it easier for innovation or more difficult? I think it makes it more difficult. This is what Congress gave us. If you want to look at what our new healthcare system looks like. The interesting thing, right down there in the corner, it says patients. And right over here in this corner, it says physicians. Now, some of us believe that the best way to reform healthcare is to put the patient and physician together in a one-on-one situation or with the family around, making decisions about what healthcare needs you have and what to spend your money on. But this new system separates the patient miles and miles from the physician and replaces it with oversight and the Secretary of Health and Human Services, with her title appearing over 3,000 times in this act, saying the Secretary shall, the Secretary will, the Secretary may, the Secretary might, as the Secretary says. I mean, it's in there so many times. There are now 159 new commissions, study groups, and grant makers, 1,968 new regulations, and policy regulation really transferred from the states to Washington, D.C. Nowhere is that more evident than in the formation of our new healthcare exchanges, which are going to be under strict governance by the federal government. I'm going to talk a bit about that as we move ahead. The Wall Street Journal a year ago in the summer reported that the cost of regulation of business was $1.8 billion, trillion dollars, $1.8 trillion, the cost of business regulation. I'm not against regulating businesses when they need to be regulated. That isn't the point of what I'm saying. What I'm saying is we spend $1.8 trillion on regulating business. We spend $2.5 trillion on healthcare. I think perhaps there are a few too many regulations on healthcare and health insurance that we might be able to do away with. But the Affordable Care Act adds 1,968 new regulations, already more than 10,000 pages. And some of them are rather onerous. Here are some raw facts. I just mentioned the number. This is approximately what we'll spend in healthcare in the United States in that was last year, $2.6 trillion. Healthcare spending has slowed down over the last 3 years. The New York Times, the Washington Post, and other non-conservative publications suggest that's for 2 reasons. One is we have a recession, and people are spending less because we have a recession. The other is the effect of health savings accounts and high deductible health plans, in which individuals engage in healthcare financial decisions as well as decisions about what to do with their bodies. And so healthcare consumerism has played a role in actually slowing that down. We have approximately 50 million uninsured, and the definition of uninsured is a little bit elusive. The term in this cohort has meant people who are uninsured for less than a year. When you start stretching that number out, the number of people who are long-term uninsured is far smaller, but these are people who have issues and tend to have short-term uninsured bouts. Now that has been affected by the recession and the fact that there are fewer people working today, even fewer people out looking for work today than there were 10 years ago, certainly affects that number. There's a projected shortage of especially family practice physicians. When we wrote our book, Your Health Matters, the projection was 40,000 shortage of family practice doctors by 2020. That has been exacerbated. It is worse than it was then. The reason that you know there's a shortage coming is because it takes about 14 years to train the physicians, and they weren't in the pipeline. So we do have a projected shortage of family practice physicians. The new healthcare law adds, in theory at least, about 30 million people to the insured rolls through Medicaid expansion and supplementing health insurance premiums in the exchange. So we're trying to figure out, how we're going to provide care for all those people if we already have a physician shortage. That's an issue. Health